Good afternoon, ladies and gentlemen. I would like to thank Dr. Dinesh Talwar for giving me this opportunity to talk about OCT in glaucoma. And I'd like to begin with this very basic fact that though visual fields are the gold standard for diagnosing and managing our glaucoma patients, however, we must remember that structural damage precedes functional loss, and 50% of RNFL loss may take place before a visual field defect is apparent. Also, RNFL thinning may occur up to 6 years before a visual field defect appears. So it is this window of patients that we can get, that we can diagnose with the OCT, the pre-perimetric glaucoma patients. In addition, it helps us to confirm whether a visual field defect is real or artifactual, and it also helps us to monitor the progression of these patients. Having established the role of OCT, let's go on to see how we do it. Now, glaucoma affects 3 areas in the posterior segment of the eye, which is the optic disc cupping, the retinal nerve fiber thinning, and the ganglion cell loss. The RNFL analysis is something we are all familiar with, the most common parameter used to follow up our glaucoma patients. So it is seen as a double hump pattern, and the distribution is given in the quadrantic map as well as a sectoral map. There are various scans that you can use, but remember to use the same scan in your follow-up. The fast RNFL scan with a 3.4 millimeter diameter is used most commonly because it has the least motion-related artifacts, but you can use any of the scans that you prefer. Also remember that the RNFL axon bundles are thickest superiorly and inferiorly, and the thinning in the inferotemporal and the superotemporal quadrants is the one that is most important. The next parameter that OCT studies is the optic nerve head, where it outlines the optic cup and the disc borders. And it gives you the optic disc area, the neuroretinal rim area, which is important, and also gives you the cup volume and the cup disc area ratios in the average vertical and horizontal meridia. Now, what is important is the scan location. If you have a well-centered scan, as you can see here, then you'll have an accurate mapping. But if you have an inferiorly decentered map, then there will be erroneous inferior thinning. And if you have a superiorly decentered map, then you'll get a wrong sort of a superior RNFL loss. What is also important is the quality of the scan. So you may feel that the scan on the top half is a very poor RNFL thinning map, but actually the scan hasn't been done correctly. And when it was repeated, you find that once you have the RNFL measured properly, the RNFL thickness is absolutely fine. So I'm going to show you a small video here which gives us the difference between the Stratus and the Fourier domain OCT, the new advancement, which takes care of a lot of these problems that we were getting with the Stratus OCT. Now here I'm going to do a Stratus map, and if you just compare the 2 OCTs that are going on simultaneously, you can appreciate the difference in the resolution that you're getting on the Fourier domain. Now the resolution of the Stratus is about 10 to 20 microns, and it takes about 400 points per second, whereas the Fourier domain takes 400,000 scans. So you have a much higher speed in the Fourier domain, and you see how beautiful the tissue resolution is and how well the mapping of the optic disc and the RNFL is done. So by the time I finish mapping the one scan here, I actually am able to do both the scan, all the 3 scans of both the eyes in this patient. And here, if you notice, it's very easy to go decentered if the patient has even a mild movement of the eye, and that decentration is what can give you a false report. So it's important that you do the scan very well when you're doing a Stratus OCT, and therein lies the role of the operator in doing these scans. This is the final end report of a patient who has a Fourier domain OCT. Okay, so now that we've established that a Fourier domain OCT can scan more points in less time and give you a greater area information with less motion error, the other important information that a Fourier domain OCT gives you is the measurement of the ganglion cell complex. Now, by virtue of its better segmentation and resolution, we find that we are able to map the ganglion cell complex, which consists of the RNFL, the ganglion cell layer, and the inner plexiform layer. And this ganglion cell complex is the one which is preferentially thinned out in glaucoma patients, and so has now become an additional parameter, in addition to the RNFL and the optic nerve head, to monitor our glaucoma patients. So this is a relatively new thing, though it has been here for about the last 5 years, but this is the GCC analysis, and this is the GCC deviation map, different from the usual RNFL and ONH that we are used to. The blue areas show thinning, which is about 20 to 30% relative to the normal, and the black areas denote significant thinning with a 50% loss or greater. And this is the ganglion cell complex significance map with the same color coding as we use for RNFL, with the red areas being seen in less than 1% of the normative database. Now let's see how these correlate with the functional findings. So this is a normal ganglion cell complex and a normal field. But if you see in mild to moderate cases, the ganglion cell complex thinning has started, whereas the visual field still appears grossly normal. And it's only when the damage reaches an advanced structural damage that your visual field defects are seen clearly. And then, of course, in very advanced cases, both the defects are clearly apparent. So if you look at the diagnostic ability of the OCT, then the time domain or the Stratus OCT works equally well if you're considering the RNFL. But if you want to look at the GCC, then it is the Fourier domain OCT that will give you additional information. Also remember that the ONH parameters are very variable, and the ones that are important are the vertical rim thickness, the rim area, and the vertical CD ratio. These have the greatest significance. Now, how do we manage our glaucoma progression? Now, if you look at all the parameters, the RNFL, the total macular thickness, as well as the GC-IPL, that is the ganglion cell inner plexiform layer, all three can be used. And progressive thinning will be seen as widening, deepening, or appearance of a new RNFL defect. But it is best to combine it with the macular thickness. Remember, beyond a certain level, RNFL will not decrease. So after about 40 to 50 microns, there will be no more thinning of the RNFL because of the floor effect, because the residual glial or the non-neural tissue will maintain some RNFL thickness. At this level, OCT really loses its significance, and at this point, it's only important to monitor the patient on the visual fields. This is how a progression analysis map looks like. And what is recommended, though there are lots of studies on it, that a 10% loss on a RNFL is significant if it is confirmed on a repeat visit, and a 5% loss on your ganglion cell complex analysis is significant, again, if confirmed. Now let's look at potential artifacts and interpretation errors. What's now come up is something called the red and green disease, where a lot of diagnoses are made just looking at the color of the map. But remember, a lot of normal patients may fall in the red zone, such as patients with high myopia, who may just have peripapillary thinning but no glaucoma. So watch out for these. Also, small focal areas are averaged when you look at the quadrantic map alone. And so you may miss thinning, and this is called the green disease. The focal areas are missed because you've only looked at the average. And that's where you may actually miss out on an early glaucomatous loss. It's important to have a good signal quality because a defocus of even 2 diopters will give you a 10 micron thinning artifact. Acquisition, we've already discussed, the ring must be concentric with the disc. And patients with hazy media will have an artifactual RNFL thinning, so much so that after cataract surgery, you will find the RNFL is improved. Also, segmentation errors and instrumentation related. A head tilt of 8 degrees will give you a wrong report. These errors have now been reduced significantly in the Fourier domain OCTs. So again, this is a map where you find that the OCT looks really bad, but that's because the scanning has not been done very well, and if you do it really well and focus it properly, you find that the RNFL thickness is actually lying in the normal range. So here are a few tips for obtaining and interpreting a good glaucoma OCT. First of all, choose the right scan protocol. Use the fast scan because it will minimize your motion artifact. Adjust the scan position. Make sure the patient is fixating at the yellow-green light, especially in patients with cataracts. Make sure the ring adjustment is concentric to the optic disc. Get a good signal strength, correct the refractive error, and ask the patient to blink or even use artificial tears. In some cases, you may need to dilate the patient to get a good scan quality. You should normally get the double hem pattern in normal cases. If there is a significant asymmetry, look at the thickness in the quadrants as well as the sectors. Do not only look at the averages, look at the detailed maps, look at the raw data as well. When following your pre-perimetric patients, go back and repeat your visual fields to see if the OCT defects are corresponding with the visual field defects. Remember, your normative database is not very large. It usually varies from 300 to 500 patients. In fact, in the Stratus, you only have 3 Indian patients out of the 328 patients mapped. So use the normative database with discretion. Use your own diagnostic thinking along with the clinical picture. Involve the patient. Show them your scans. Let's say you have a patient who's very worried, has a bad visual field. Show them that your scan is normal, you don't need to worry, and just keep them on follow-up. On the other hand, if you have a patient who's very erratic with this medication and you show them that their scan is really poor, they might actually get convinced to be more compliant with their treatment. Remember, it's a costly investigation. You usually do not need more than 1 scan per year to 2 years. And also document whatever you see. So even if you have a hazy scan, write that down that it was hazy because of poor patient cooperation or a hazy media, so that 6 months later or a year later, you are able to interpret a repeat OCT or a repeat visual field with better clarity. Finally, OCT is a useful diagnosis to validate, a useful technology to validate a glaucoma diagnosis. Like I said, evaluate the scan data, not just the color codes. Repeat an OCT before you take a treatment decision. Remember, your individual patient that you're following up will give you far more information than just the OCT normative database. And you're not able to detect pallor, disc hemorrhage, etc. So please combine the clinical exam, the IOP, and the visual field. To conclude, in our classical glaucoma diagnosis of eye pressure, optic nerve, and visual field, OCT forms a useful adjunct and gives us a lot of additional useful information to help us manage our glaucoma patients better. Thank you.